Yasas and welcome back. You can't grow bone or gum without blood. PRF concentrates what healing needs most: cells, fibrin and growth factors. Today we're going to talk about the biology, the evidence and where PRF actually moves the needle to our favor. Shall we discuss a bit of history first? So since many years ago, surgeons noticed that surgical incisions in areas where hematoma was formed showed signs of better healing. This was the concept that the PRF pioneers used and started working on the blood concentrates that we know today. The very first generation of a blood concentrate, the PRP, was introduced by Robert Marks and his team in 1998. A team of oral and maxillofacial surgeons from the University of Miami Jackson Memorial Hospital. Marks and his team used anticoagulants, and the protocol included several steps to achieve a usable product. Then, in 2001, comes Joseph Chocroun from Nice, France. Dr. Chocroun's protocol included single centrifugation and no anticoagulants. This led to the creation of PRF as we know it today, which basically consists of dense fibrin matrix with high number of platelets and leukocytes, which release growth factors slowly for up to 10 days. Since then, many hundreds of scientific articles have been published and many studies have been conducted on PRF. What is PRF? PRF is part of a blood clot. A glorified clot, as I say at my courses. It is basically autologous fibrin matrix with platelets and leukocytes. No anticoagulants, and this is a big no. Why a big no anticoagulants? Because we want to keep everything natural as biology intends to heal without any chemical additives that do affect the cells and growth factors contained in this amazing vehicle of biologic power. The platelet-rich fibrin forms a slow-release reservoir for the growth factors like PDGF, TGF-beta, VEGF, IGF, and so many others. It acts as a scaffold for the cells to grow and divide, and also as a signaling hub, calling the right cells and ingredients needed for healing. How PRF drives healing? Let's take a step back and think about healing for a moment. Remember what we were taught at college and university. The first thing that needs to happen for the initiation of the healing cascade is a blood clot. No clot, no healing. And let me remind you, a very painful complication that can happen, thankfully not often, after tooth extraction: dry sockets. Just because no blood clot was formed. We all know how painful it is for the patient and how much time it takes to nurture the patients and keep them free of pain if possible, and it takes a long time to see healing in these cases. What does PRF stand for? P for platelets, R for rich, and F for fibrin. What does fibrin do? It looks like a 3D net that helps to trap cells and guides migration. What do growth factors do? Their sustained release supports angiogenesis and matrix deposition. What about leukocytes? They help with the early debridement, cytokine signaling, antimicrobial support. They're also a reservoir for growth factors, especially for the vascular endothelial growth factor, which is extremely important for the new blood vessel formation. Can you think of a reason, based on biology, why some blood concentrate systems out there remove leukocytes from the equation? I personally cannot. It makes zero biologic sense. So protocols matter. Ideally, we should use low relative centrifugation forces that retain more cells and enhance vascularization in PRF matrices. A-PRF, S-PRF, I-PRF show higher cell content and factor release than older L-PRF settings. And this is what the Chocroun system offers. Every now and then, I'm asked to give my opinion about inexpensive centrifuge machines and systems coming mainly from Asia, and if these can be used to produce the PRF that we all know, which we've been taught and seen in the literature. My reply is simple. Is there a way to make sure that these machines deliver the same G-force exact RPM and match to tube radius as the machines that are sold with the known systems? If not, then how can we expect to get the same product as the one that has been referred to in the studies? This is the reason that I insist to use the right centrifuge machines and consumables for consistency. Let's talk about outcomes now. When it comes to hard tissue, let's see what outcomes we can get, based always on the studies. Extraction sockets. PRF reduces alveolar bone loss and improves early healing in multiple studies and meta-analysis. Suggestion. It works much better in the posterior area where we have thicker bony walls. When it comes to the anterior area, PRF on its own will give some result, but not on its own. It's usually best to mix it with biomaterials. What about ridge preservation? So PRF shows less width and vertical loss than natural healing in some studies. What about sinus augmentation? As an adjunct, PRF improves early graft maturation and some stability metrics in pooled analysis. Evidence is positive, but heterogeneous. Let's see what happens with soft tissue outcomes based on the studies we have. Keratinized mucosa and thickness. So PRF can increase the keratinized tissue width and soft tissue thickness around implants versus controls. What about PRF and soft tissue grafts? Early studies suggest that PRF can thicken peri-implant tissues, though connective tissue grafts remain the gold standard. What about studies on third molars and sockets? PRF has shown that it can lower the osteoarthritis risk and often reduces pain and swelling in meta-analysis. But where PRF helps most? I would say in complex sites needing vascular jumpstart, like sockets in thin biotypes, simultaneous grafts, sinus lifts, and soft tissue thickening around implants, adjunct to xenografts, alloplasts to improve integration and early stability. Personally, I think that the use of PRF helps in most situations in implant dentistry. At least 80% of my patients do benefit from it. Let's not forget a practical reason for using PRF with grafting. It helps vastly with our bone graft material handling. Once we prepare sticky bone, we do not need to chase our graft granules around, and handling becomes much easier and our field much cleaner. Let's have a look at some limitations and nuances based on the studies we have. Not all studies show clinical gains in simple extractions. Perfusion and pain benefits can be minimal. Now, we have to remember that technique sensitivity is real, and also the tube types that have been used, the G-force that was applied, the time and clot handling. So ideally, we have to standardize our protocols. I think this comes down to comparing different protocols and surgical techniques without consistency. PRF is not a magic wand. It cannot replace solid surgical technique. It can only enhance it, but can never make bad surgery go away. My take-home message is the following. PRF is biology in your hands. Scaffold, signals, cells. Use it where vascularity is the rate limiter. Standardize your protocol and expect modest to meaningful clinical gains depending on the case. If you want a follow-up video with exact centrifuge settings, tube selection, and sticky bone workflows, say PRF protocols in the comments below. Thank you.